Hi, good morning. Hope you are doing really well. Thanks very much for joining me. I'm super excited about showing this case. This is my latest newsletter, and it was Jackie that I presented. So this is newsletter 76. And it was a tricky case because we've got old telescopic attachments in the lower. And in the upper, we've got these precision attachments. So I'm going to go through this full protocol and just chat through with you about it. So this is a treatment process. So I saw Jackie in 2021. This is when she presented, and literally just after COVID, and I'd started doing my Zoom consultations then, which I found really useful. You can see we've got Jackie here. She used to live in Germany and had this work done 6 years prior to 2021. And she's got this lower bridge, this lower implant supported, telescopic crown supported overdenture that's broken. It's porcelain, gold, and plastic. And she can show me this. And it's really, I think Zoom's just a terrific thing, because the patient can really just go up to the screen and go like, hey, look here, we've got these things going on, and show me inside the denture there too. So I'm going to just show you what's going on with this case and how I fixed and restored her. So now what I'm going to do is just at the moment, I've got two screens here. And so I'm going to put up the Q&A bit here, and um, I'm just going to put up the question and answer box and also the webinar chat. So I've got those things just there too. So it's fantastic. I've got a little message from Ian over in Denmark. Hi, happy Easter, Finley and Rowan. Morning run with headset and lecture with Finley. Life is great. Brilliant. That's great. Lovely to hear from you, Ian. So, throughout the whole of the webinar, please just put in your questions into that box so we can have a nice discussion about this too. Let's go for it. So, these were Jackie's concerns. She basically didn't, she's got this fractured lower, she called it a bridge that sat on those telescopic copings. Um, she wanted that replacing, and she also had that loose upper partial denture because there was a missing attachment on that too. Her wish list was a new lower bridge and improved fit of the upper denture. Interestingly, she had absolutely no concerns at all about the aesthetics. So obviously, apart from where it's just fractured away there, but the rest of the whole thing, she was happy with. And I think one thing that I just really look at in particular when I've got a new patient in, particularly when I'm getting these photographs done, I want to see what they're going to look like. What's their full smile going to be like? How much gum are they going to show for those upper front teeth there? And interestingly, she does show quite a bit of that gum work. And if she did have wire clasps, they would show on those upper teeth. She's got upper 3 to 3 there. So this is her with this on presentation when she came in for a consultation. You can see that the porcelain's fractured away from the lower implant bridge, not implant bridge, but the telescopic supported bridge, the bottom there. So, and this is often a problem with these sorts of things because there's a lack of space for all of the restorative materials. It's really tight for room in these areas to put the teeth back in the right place and also for the whole thing to be quite strong as well. So that's where the bridge had fractured. So she's got reasonable oral hygiene. Let's have a look at the top there. We've got these linked crowns. So this is a bridge at the top here, 3, 2, 1. That's a linked bridge, and then we've got separate crowns, 1, 2, 3 there, and then off the back of these are little rods where a slot attachment can fit. And then this is the lower arch here. We've got these telescopic gold crowns. That's been root filled. You can see that through the top of that. And that's an issue with these sorts of things because they do have to be prepped quite heavily to the teeth. And often, quite often we know that, with crowns that at least 25% of them devitalize. So it's a, common issue. And this is the lower fractured overdenture there. Let's have a look at the upper. When I looked in her mouth in particular, I could see that, we've got these linked crowns, and then we've also got an attachment on there that used to fit inside the denture just here, but it had come off and it was actually wedged into the gingiva just there. So I just pushed up. It must have been quite uncomfortable, although Jackie didn't mention it at all. She didn't complain at all about that. But that was embedded in the gingiva like this. And, just looking at that there, you can see it's been pushed right up into, just basically just cut away up into the gingiva. So sticking up here, and there's a little bit of inflammation there. Just let's go back. I'm just going to, all of these crowns are actually linked. So they're not split at all. So we've got a bridge, missing lateral incisor, and then 5 abutment teeth underneath this, which helps to support the precision attached retained upper denture. And it's really, what's really important is to link crowns. If I think that's an important point if you're considering doing a precision attached denture. It's always good to have it double abutted because they will pull on that distal abutment and cause a complete breakdown of attachment of these teeth. So having them at least double abutted is super important, although I really don't like them just because of the complications that can occur with them. So anyway, what I did was I just popped at this visit, I just popped a little bit of local anaesthetic in there, and then just lifted this out. Just got a flat plastic on it, and just got that attachment out there. Gosh, that must have been so uncomfortable for her, because I know that I had a little piece of, I think a little nut or maybe a seed that just got stuck here for a couple of days just a few weeks ago, and it was terribly uncomfortable until I just got a scaler and just got it out. So these things must really be a little bit uncomfortable. So I took some radiographs just to make sure there's no areas underneath these teeth. Now, what I do find is, and it's with treating these types of cases, is finding out what type of attachments we have, what make they are, what shapes and size, because there's lots available throughout the world. But fortunately, Jackie she knew which dentist she'd been to in Germany, and they were really helpful. I just emailed them, and they sent me a list of all of the stuff they'd used with all the parts. So I was able to find out that these attachments were actually Bredent, this VarioSoft 3 matrix here. And Bredent are a really well-known attachment manufacturer in Germany. So we knew exactly what size those rods were up at the top, which is great. So this was the treatment plan that I decided to do, was to, number one, make a new lower overdenture. Just keep those existing gold telescopic copings. I'm not going to take those off. It would be expensive to change them and everything. Just keep what we've got. Also, taking them off would potentially cause more problems with the dental nerve and potential RCT issues. Moving on to the upper, I wanted a new upper RPD, which fitted onto the existing rod attachments there. Um, because Jackie was totally happy with the appearance of those crowns, although they were quite opaque and looked a little bit blocky, a bit those linked crowns at the top there. I just know that, taking them off, replacing them, it's going to improve the aesthetics, but also it's going to open a can of worms, potentially with root canal issues too. So we chose not to do that. Plus, that would have increased the expense massively too. So that's what I decided to do. This was the list of appointments that I wanted to go through here with all of this. So we've got primary impressions for doing mounted casts. I think with these cases, I think it's really, I do like to, along with Rowan, is to have a look at the study casts, get those mounted up, and just see what space we've got to work with, what's the vertical that we've got to work with too. So, and then next visit will be working impressions, do a bite registration, and prescribe where the teeth are going to go. Number 4 is a try-in. Number 5, metal-based try-in. And then number 6, a fit. And then review the patient. Now, also, I think warnings for the patient too is, I think, super important are that particularly in the lower arch when we're replacing an existing telescopic bridge denture, the fit of it will not be as good as the original because we're making a new framework to fit over the top of the existing gold crowns, and they're not made together and they're not cemented together. So the fit won't be quite as good. So let's move on. So this is my technical team that helped me with this. So Chris was going to do the metal work, Chris Hesketh, Rowan do all of the technical planning, and then all the prosthetic work on top of that. And I would do all of the clinical work. So I do like to just design things and do a bit of colouring in before I start the whole process for the patient. And I felt that the new design, if you just focus on the upper here, the new design for the upper denture would be super important. I didn't like the way that the old denture didn't have any bracing on that canine or moving onto the lateral there. It was just literally retained by that rod and then supported by the tissues distally there. So I felt that it would be important to add those bracing elements. I'll bring that in just in a minute later. Looking at the lower design here, we've got these abutments, which are the gold telescopic copings underneath, and I've purposefully not coloured in any pink around them because we've got all of the root structure of the tooth there. So literally, this is going to be, it's a removable bridge, and the only areas where we need the pink are the areas where we have missing teeth to replace the missing alveolar gum tissue too. So here we go. Visit 1, primary impression. I want to get a nice impression of the free end saddles. So I mix up some red cake compound like that and then put some adhesive, alginate adhesive on that. And then I then do my primary impression. So here we go. Here it is in the mouth. Now, I apologise, my this is a head cam, so I can't sometimes see exactly what the camera's showing. But here we go. Claire's got the little retractors in. I've got alginate on my fingers. I'm using dense ply blueprint cream mix alginate, rubbing it into those rods. They're called patrices. I've got a nice firm mixed alginate here. Take that to the mouth, sit it up at the back, and then rotate it over the front and sit it down over those front teeth. And then gently just push that up, and then just do a little bit of massage of the lips, just there like that. Produces a lovely impression, fully extended, which is really important for producing the special tray. So, by the way, if you have any questions this morning, please just stick them in the Q&A box, and I'll keep referring to those throughout this presentation. So what I do is mix up some red cake compound. This just is, and then push that into the mouth to record the free end saddles there. And then I mix up some alginate, put that into the tray here, and then rub the alginate into those abutments there. So this is for my primary impression. Just pick up the alginate, rotate it in, sit it down. And really importantly, when I'm doing this, sitting it down, you ask the patient to lift up their tongue. I want the tongue out of the way, so lift it up, Jackie, like that, and then just rest your tongue. And that just gets it out of the way. And then gently close together and just do a little bit of border moulding, but it's really not important, the border moulding, but it still produces a lovely impression specifically for producing a really good custom tray. And you can see that this, we've got a lovely impression, even, all these crown margins too. It's fantastic. So, hi Bryn, morning, hope you're well. Morning, Finn. I was going to ask if you needed to block out beneath the patrix to prevent alginate tearing, but obviously you didn't need to. That's right. So, no, I'm not bothered about alginate tearing either. They will go around things, and it does tear when I take it out, but it springs back. So, and when you see these study casts, they just look ace. So, that's great. So the other thing I did at this appointment too, because I wanted to mount these just to have a look at them. This isn't for producing. It's not for producing the final restoration. It's just purely for study casts. I did a bite registration using Futard, the bite registration material. Just got the patient to close together in approximately the intercuspal position here. So. Now, just a little point. I want to just raise this. This is just a little bit of a side point, but a super, super important point, which is something that I really didn't realize was whenever attachments are used, thought must go into what the bite's going to be like without the dentures in, because at some stage the patient will go to bed without the dentures in. And if we've got studs or these metal components sticking out of things, the patient can really brooks on them and absolutely wreck opposing teeth and snap things, and it can be a total disaster. So thought has to be made and taken into account in terms of what will the bite be like without the prosthesis in. Just something to think about. And if you're ever thinking about doing precision attachments, please think about that too. It's a really important point. Anyway, let's go back to the study casts. Zoom back here. There we go. So I've got that bite, but look at this. And this is Bryn, you were talking about that. look at how crisp those slots are on there for my study cast. But I know, which is great, I've got enough extension for producing a really good custom tray. So these are the study casts mounted. So Rowan and I can look at this. I know this is overclosed. You know, this is the bite record that we took. So we can open them up and then we can have a look at what we're working with. And Rowan, he was like not looking forward to doing this at all because he knows that he's just going to be stymied for space. Totally. Right, let's fast forward. Most of my appointments are 2 week intervals in between each visit. And I think, particularly when we're doing something really quite technical like this, I think it's really, I do like to give Rowan and Chris plenty of time. So there's 2 weeks for this. For the metal work, I do like to give them 3 weeks. And often for finishing 3 weeks too. I don't want to rush them. I just don't like to do that. Rowan repaired this just with some composites. This is the lower bridge, the lower overdenture. We didn't fix it. We didn't glue it together. It was still in two pieces, but you could pop it back in, it looked better. And that's like fine. You know, we're not having to rush and get this stuff finished really quickly. This is my upper custom tray. That's my lower custom tray. And then we'd done our research, so we'd found out that these attachments here with this were Bredent Variosoft 3. And so that's the attachment in the mouth. And Chris, what he did was he got a wax pattern of this shape and then cast it up in chrome. So he produced an attachment replica, and we got an impression pickup from Bredent that would just slot onto that. So I could then do an impression of that in the mouth. We could then fit that into the impression and then cast up the model and have metal patrices on the model. I'll just show you what I mean by that. So the impression pickup's placed onto the rod in the mouth like that. It's placed both sides like this. I then take an impression tray and I do border moulding with green stick. I just imagine that these free end saddles are just like a complete denture, and I do my border moulding just as is. And then I like to use Impri gum for these. So this is Impri gum regular, just like I would do for a implant restoration. Very, very accurate and solid. So that goes over the impression pickups, and I do my border moulding just like I would do for a complete denture, pulling the cheek, getting the patient to waggle their jaw open wide, and then take that out. So this is it here when I take it out of the mouth, and you can see my impression pickups, rather like doing an implant restoration there. And then into those impression pickups, those cast chrome patrices get pushed in. You can see here, so we've got two of these that Chris has made. I just push those into those impression pickups, and then the working cast is poured. And so we've got a great working model to work with just there. So we can actually make a really, we can make the denture on that, and it's just going to fit onto those slots beautifully, just like that. So now the other thing I think is really important just to note is if you look carefully here, I've done some preparation of the canine and also distal of that lateral incisor on both sides, because I want some really lovely solid bracing wings on that. I don't want the denture just purely supported by these and really cantilevering that upper bridge. So I've just trimmed that out so it's not going to affect the occlusion, so we can fit it into the existing bite. there. So look at that. Lovely rods on that working cast. Let's move on to the lower impression. So I'm going to do border moulding, buckley, like there in those, just on those saddle areas, and also border moulding on that lingual section too. And then I put my Imprigum adhesive on, and then I take this to the mouth. Now, I have to apologise, I'm really sorry, but my camera was not really showing you what I was looking at here. It's attached to my loops, but you can see I'm squirting around those gold abutments, some of the Imprigum. I then pick up the tray, rotate it over. This has got the Imprigum loading it in. I push firmly down so that the Imprigum and the impression tray seats onto my compound stops. And then I do my border moulding. The border moulding's important for those buckle areas there where we've got the free end saddles. I just take off some of the excess and then just push it down with my fingers, pressing down onto the premolar areas. I'm sorry you can't see that. But what Jackie's doing here, she's really moving her tongue. I wanted to get that tongue moved because I want to make sure that I've not overextended the impression on that lingual area and that the final lower telescopic bridge will not be restricted. So that's my lower working impression. Now, if you look here and you think, oh, this is all unsupported Imprigum here at the front there, it's just not important because the denture's not going to go down there at all because we've got all those abutments and the denture's going to be finishing much higher up, very close to where the abutments are. But further back there and there, it's really important that's border molded nicely. That's what I was thinking about anyway here. So nicely border molded lingually with the tongue. You can see where I've pressed so that the saddle I've actually pushed down, so the green stick's pushed right through, so it's really well supported by that distal free end saddle here. This is an important point. I know, Bren, you've been in touch with me about this case, and you've asked me about altered cast technique. Now, I don't think we need to do altered cast with these because, which means altered cast is where we do an impression for the front section first to get the metalwork fitting nicely, and then for the free end saddles, there's a separate impression made. This, I think, takes this into account, and we can get some compression of the tissues with the green stick. And you can see I've got nice crown margins on those too. And this model gets poured, and Rowan did this with these with Duralay. It was either Duralay or GC pattern resin. He poured those, so that means that these are quite resistant to abrasion, and then we can then make the gold work to fit over the top of those later. So we can now fast forward to visit 3, which I think is super important. It's super important this stage to do the registration and then do the wax trying of the teeth before we get the metalwork made. Really, really important. So I want to know where we're going to put the teeth first. So at this visit, I wanted to do some wax rims to prescribe just where I want the teeth to go, and also to get the right vertical dimension there. And then secondly, I wanted to restore Jackie to centric relation, and so I'm going to use the central bearing apparatus to do that too. So that's what I wanted to do at this registration visit. Also, what I wanted to do was just to verify that I had a really accurate upper working cast. So Rowan made me a pattern resin jig that fitted onto the metal replicas and also fitted down onto the teeth as well, just where my rests were going to be, onto the rest seats on the teeth, and it just slotted in beautifully. which is really lovely. It's a bit like a verification jig for implants, no different. We took the shade here, which is A2 for the teeth, and then I trimmed up the rims upper and lower to get the right vertical and also to get the right buccal corridor. So we've got this in place. I take some photographs just to make sure, and this goes through to Rowan so he can then set the teeth up and also make any corrections if he feels I've over trimmed it, maybe in that area, so he wants to just bring the smile out a little bit there. He can do that when he sets the teeth up. So I do think these photos are just wonderful for that purpose. So the next part of the appointment is I want to just record really accurately CR. So this is a base plate that's made to the working cast at the top there. And then on that base plate, I warm it with a Bunsen and then using a China graph wax pencil, put that onto that plate, let it set, and then take that to the mouth. So I fit the lower one down first. So this is the lower with that central bearing pin, the stylus, into the mouth. The upper goes in. You can see that's at the back there, at the top there. So we've got a stylus biting onto the plate. And then I asked Jackie to move around. So, and this is it in the mouth there. So I get to move side to side, go forwards and backwards, move anywhere. What's really important in these cases as well is that we're not interfering and touching the teeth. I just want the stylus to be touching without these copings hitting those teeth. So sometimes I've got to open the screw up a little bit on that just to allow that to happen. And so she moves around and she produces a lovely, beautiful arrow, absolutely bang on where CR is, super accurate. And then on top of that, I fix a disc which has a hole in it, a little countersink hole right over the tip of that triangle. I stick it on with some wax and a wax knife. And then that goes to the mouth. I just get her to bite together into that so that the stylus here goes straight into that hole, and then she's held in that position, and then I can inject Futar D into that, and I've got a fantastic bite record. Just take that out of the mouth. Look at that. That is so locked in. It's fantastic. Also, what I do at that bite registration visit, on the carved upper rim, I do a bite fork. And then that means that we can mount the upper working cast using that face bow. So this is what all goes back to the technician. This goes back to Rowan. If I just point things out, we've got the working cast lower there with the replicas. That's the working cast upper with the metal rods. So this and that will be mounted. So this wax rim here will mount the upper cast first onto the articulator, and then this here, which is the central bearing apparatus, will mount the lower to the mounted upper. And then Rowan can do a denture try-in too. So here we have the wax try-in there. So Rowan can mount up the casts and then fix and actually put teeth on. So there we have it. So that's the upper try-in with a shellac reinforcement base. So let's have a look at that. Bren, you've asked a question. When you are registering the OVD, how much space are you needing between upper bridge and lower copings? Same as if you were placing a bonded bridge on the lower. So I would be looking, Bren, because we're going to make the lower with this. The lower is going to be, it's going to be denture teeth that are hollowed out, sitting over the gold framework, we want to have really 2 millimeters of space at least. So gold and then 2 millimeters of space for the acrylic work. So really, ideally, 2.5 millimeters. So that's what I was looking at really for this. Um, but what I did, Brent, was I wasn't really thinking too much about that at the jaw registration stage. What I was looking at was to make sure that she looks good with the wax rims in place, which is this there. So, just looking at it with both upper and lower in, is the vertical correct with them in? And then we get that mounted. And if we need to jack them open a bit to give them a bit more space, then we just have to do that, to give the technician enough space to do it. So ideally about 2.5 millimeters of space, which is quite a lot, isn't it? Right. So let's go for it. And in these sorts of cases, I'm always really stuck for space. So that's the lower triangle. He's hollowed out those lower teeth. And then I can then take this to the mouth. So this is the wax trying, making sure everything looks good, doing my photos, also having a good look and letting Jackie have a really good look at herself, having a look in the video, making sure she's totally super cool about this. Because I have increased the vertical for her there, you can see. And so, the lowers are going to be showing a little bit more just to give us a bit more room there too. Also, I just wanted to double check. This is at the try-in visit, just to make sure that these fit really well. So these are the pickups on there, another Duralay slot, just to make sure I've got the right height and it's all perfect, ready for the metal base try-in. So pacification, verification jig there. So let's go to visit 5, get the metal bases made. So what's super, super important, and I really want to emphasize this, and if you come on any of my courses for partials, I do think it's really important to get the metal, do the tooth trying first, and then that means that the metal work can be engineered to fit into where the teeth are going to go. Super important. So, hi AK, are you checking midline in try and visit? So let's go back to that. AK's asked a question about midline try-in. So there we go. Not at all. I don't, AK, I do not care one little bit whether center lines marry up upper and lower, because if you look at natural teeth, they very, very rarely do. So not an issue at all. I'm just not bothered. And in fact, I have never had a patient yet worry about centre lines marrying up. Having said that, though, I might have someone next week that talks about it. So, no, centre lines just not an issue for me. I don't care about them at all. But it's an interesting point, AK. So, let's just have a look here. So these are the metal frameworks. So in the upper, I was using chrome cobalt, and that's the alloy that we use, which is actually called Wiranite by Bego, Wiranite. And then in the lower, because we've got these gold copings, I wanted to use a high gold content base, but hard, which then fits over it, which has got these like nice little beads to allow the acrylic work to really bond onto that. But I didn't want to have galvanism between the two metals touching there, and this sort of like metallic taste and battery setup. So this is the upper chrome, and I just want to make sure it's fitting straight away. So this was the first thing that I did. Just tried that in the mouth and just gently seating it over those areas. When I'm trying in these metal things here. I'm always quite careful that I don't press too hard because I don't want it to wedge itself in, number one. And secondly, I don't want to hurt the patient either because sometimes, some of the metal can just dig in and it can be really painful. And if it's wedged in and it's really painful, it's a problem. But that fitted just beautifully, which is great. It just sat down really lovely. And then I could just get my fingernail underneath the edge and pop that out. So this was it here. You can see it's fitting right down onto those rest seats beautifully. The freehand saddle section was fitting nicely onto the pallet there, which is great. So that's really good.
Here's what I found.
So let's just have a look at the lower now. When I tried that in, it was pretty tight. So it wasn't as good as the lower. It was a little bit tight. So I could push it down, but it was almost like wedged onto those teeth. So I had to think about this. Do I accept it's tight? This is like super important, my thought process. Do I accept it's tight and then finish it and then allow it just to settle in? Because with all of those natural teeth there, with their own periodontal ligaments, they will shift a little bit and just slot in, like orthodontics. So do we accept that? Do I adjust it with occlude and make it more passive? Or three, do I section, cut it there and section it in different places so that it fits totally passively and then fix it together in the mouth with pattern resin? I went for what I thought was the easier option really, which is to adjust it. So this is what I did. I like using this occlude for it's a powder spray, arty spray, occlude spray, various on the market. I just spray it onto the fitting surface like this. Take it to the mouth. Push it down and then give it a wiggle, just really get it pushing and then take it out. And then where I can see it just holding off, I use my speed increasing handpiece there just to drill on those parts that I can see have rubbed off. So I just do that on those areas. It took me ages this to get it fitting really passively. It probably took me about 20 to 30 minutes to do this, just step by step, just really carefully, just popping it back in and adjusting it until I was happy that it was just sitting passively without it moving any of those teeth. Do you know what I really wished I'd have done though? I really wish that I'd just not bothered doing that and finished it and just let those copings, the teeth just settle in because I think the fit would have been better looking back. So anyway, that's it there. We got it fitting. And then we'll just go now to finish. So Rowan finishes everything. Finishes the upper teeth and lower teeth. These are all acrylic based with, finishing the acrylic work on top. And it was so funny doing this whilst it isn't really, it's funny looking back, but it wasn't funny at the time. Rowan hated it because he was so restricted for space and particularly this lower bridge. But anyway, let's just look at the upper here. I do think these little features are so important. Having bracing elements on this upper there, just to resist rotational forces, it increases stability, it puts less pressure on that cantilever section. So important with this there. So it's got this attachment in. And then this is the lower overdenture there finish. So this is what Rowan was hated, trying to disguise all that metalwork underneath with these acrylic teeth. Now, this is really important, and I know that probably some of you probably thinking about this, is that some of these telescopic overdentures, actually the teeth are not finished in acrylic, they're actually porcelain. So you've got porcelain bonded to metal, and then pink in composite, and for the back bits. Now, I could have done it like that, but I think this is really, really important, is I'm so used to working with Rowan. I know what he can do. I know what his work's going to be like. It's so predictable and it's so good that compromising with using acrylic teeth here and these denture teeth is a better solution, and jacking the bite slightly more is a better solution than me using a different technician, someone that I don't work with very often, finishing the case which won't look quite so good. It's so important. So these are the details I'm thinking about. I do not want to compromise on that, because I think the technician is working with what I've got, which is a great acrylic technician. So let's go to the fit. Now, the occlusion was pretty good. I tested that, but one thing, and the upper was great too. Now in the lower, it hurt, and it hurt on this freehand saddle. This is the long freehand saddle, and if you remember my working impression, you could see that I'd used that compressive technique where the compound pushed through. So, but it hurt on that area when she bit on it. So this is what I did. I put some silicone on here, took it to the mouth. This is a fit check. I love it. Light-bodied silicone. Pop it on. Push it down. Press it firmly down. Get Jackie to bite together firmly. And then take that out when it sets. And you can see that this is where it's hurting. It's pushing through on that area. And she said that that was sore. So I just mark that up. I pop it into some disinfectant first, mark it up, pull it off, and now we've got a nice mark, which all I need to do is grind that off. So I like using a tungsten carbide, but the other thing is if you're doing a lot of prosthetic work, I would highly recommend having a lab handpiece, a proper technician's laboratory straight handpiece, rather than using the one on the unit, on the dental unit. They work much better. And then just polish that up with the polishing rubber. Just finish that there. So I just repeat that process until it's totally comfortable. There, and this is it finished in place. We've always got these little spaces, we've got this, aesthetically, if this was visible when the patient functions, then that's going to be a failure. Not particularly happy about this. This could be better, having no pink there, but just having the white of the tooth extending right up to there and having the pink work starting there. That's what I'd like to improve on that case here. Same on this side. I'd prefer it if we could just not have white, sorry, pink there, and that'd be all white, coming up to there. So it's got a proper root surface sitting into the gum. This is the lower fitting. You can see it just fitting beautifully down onto those gold abutments there. So that's the denture there. So with our lovely bracing elements on there. So this is what I know I've been harping on about this, but I think it's really, really important. This is the old RPD, and they do put a lot of force on these anterior bridge work. Now it is all linked, yes, so that's going to reduce that. But I just think having these extra little struts there is going to really help with that. Now, to make the lower fit really, really well, it was a little bit baggy, so the retention wasn't fantastic. The stability was great, the support was great, but it just had. I used this material, and this is designed again, it's by Bredent specifically for these cases where the gold copings have worn down and the fit is a bit slacker. It's a resin which mix up, and then I sandblast the metal, mix up the resin, pop it in, and then put that in. And it's whilst that's setting though, it's very important that I move it in and out so that it doesn't lock onto those teeth. It's a bit like picking up attachments for a implant overdenture. Super important. When I was doing this though, flip it out, there's always things, aren't there, that happen. This happened. That gold coping came off the root treated tooth there. So I sandblasted and cleaned it up and then re-cemented it in place using Fuji Plus cement. And whilst I was re-cementing it though, so I mixed up the cement, put that on, and before the cement set, I made sure that the bridge was sitting over the top of it. That removable denture was sitting properly over the top with it biting together so that the gold coping was properly seated in the mouth. So that's the case there, finished. So thanks very much everyone for listening. If you've got any more questions, just stick them in the chat there. I know you've probably got work to go to now. You've got patients to see. So it was worked out really well. And you know, she lives really locally to me. So this was finished in 2021 and it's been functioning really well since then. So we're 4 years down the line. Interestingly, she'd only had 6 years of service of it when it had been done originally. So the points that I make, I think, are really important are these things are really expensive when they're done in the first instance, and they're really expensive to fix. So I just don't really like these attachments. So looking back with hindsight on this, the patient was really happy, super happy with it. I didn't like the look of the upper six crowns, really didn't like it. And we could have improved the smile. Rowan really did hate this case, I have to say. It's just a lack of space. He he grumbled the whole time about it. But we got there. So I think the lesson learned is that we've just got to sometimes just do it, do the biz, even though it's difficult. The fit was really hard to get right, so I used for the lower bridge, and I used that FGP resin at the end, which I think was really useful. But looking back with hindsight, I think it probably would have been better just to finish the framework, the metalwork, without adjusting the fit that fits onto those gold copings and just let her wear it. Because what I do find is that these really snug partial dentures with metalwork that fits onto the teeth, if it's not quite seated at the fit appointment, when they come back, they do, because the teeth just settle in. Just like with orthodontics, settling in is really important. Jackie was a great patient as well, and she was really patient with me too. So, Bryn's just asked another question here. She's lovely. If you needed to remake a gold coping due to, say, recurrent caries, would you retro make a new coping and then use the Bredent resin afterwards if needed to improve the fit? So if yeah, I'm not Bryn, I've never needed to do that for a case. I have, as in retro, I have had to retrofit crowns into existing partial dentures. So um, I think we would probably do a scan of the original coping of the cast that we have, a scan of it, and then make it to fit, and then either allow the thing to seat or use FGP resin. So, hi AK, thanks for answering. I'm from Vancouver. It's 12:30 at night here. Knowledge is very valuable. Hope to see you in certain person in your hands-on course. Hi, absolutely, AK. Thanks for that really good question. So before we finish, these are my courses that I'm running at the practice during the year. So I've got the partials course. I run 4 different courses: removable partials, complete dentures, implant overdentures, and immediate courses too there. And also, AK, I'm in North America in February in Texas, which may be worth coming over to there. And if you look on my newsletter, it's there too. And that's great. So, anyway, thanks very much for listening. My next study club will be May the 1st, and it will be at 7:30 in the evening, British summertime. Anyway, cheers now. You all take care. Have a great day and good luck with your dentistry. Bye for now. Bye bye.